Well, good morning, everybody. This is Dr. Peter Plantis, and I'd also like to introduce Josh Yellen. We are from HC1. We are a bioinformatics organization coming out of Indianapolis, Indiana. Josh, you want to say hello to everyone?
Good morning. Look forward to this presentation, and thanks for the introduction, Dr. Pete.
I am the physician executive of HC1. HC1 has been a company that's arose about 9 to 10 years ago, and it started in terms of bringing together all of the laboratory data throughout the country. It has grown so that now up in a cloud application on Amazon Web Services that there's over 21 billion laboratory transactions covering over 160 million people. And it's that data that leads HC1 to be able to offer the analytical engine that brings insights into that data. By de-identifying the data in bulk, trends could occur, but then those insights can actually be applied to individuals for precision-based medicine actions. I'll always like to give the example that if you were tracing the cholesterol of many, many people, millions of people, and you saw the downward trend over time, but then you have an individual that the cholesterol doesn't move despite medications, the ability to translate that into action indicates that the medication for that individual may not be metabolized according to how that person's genome is designed, and therefore you need to change the medicine, okay, to trace and then watch the laboratory data show that the cholesterol finally moves down for that individual, and thereby lowering that person's risk of cardiovascular or stroke event. So again, hundreds of laboratory companies have signed up. And when we get specifically here to the application of all this technology to what emerged this spring with the COVID pandemic, that there's literally hundreds and actually over 2,500 laboratory draw sites where people were getting their tests for the viral genome, that all that data is streaming in through this platform. And as we saw that happen in March, we took action immediately to harness that data to be able to show where prevalence of positive viral tests were occurring county by county or sub-county areas within a county, and be able to show actually where the prevalence was emerging, where hotspots were emerging. Now, the importance of COVID-19 testing to you in the laboratory industry is very important in terms of it's a driving force behind your hospital volumes or your laboratory volumes and the outpatient clinics. We've all seen that there's been a major disruption in the outpatient flow because of the concern of transmission in the medical spaces, and hospitals themselves, which are the site of taking care of the severe cases, have had dramatic shifts in their patient populations, of having to cancel the elective surgeries, which often are the most high margin generating cases for those hospitals. Laboratories need to understand the prevalence rate in the area that they serve geographically, because if you don't react to the changing COVID, you will not be prepared in the laboratory for what could be a rather rapid shift of needing to move away from standard tests because of the lack of elective cases or surgical cases, and a rapid movement towards those laboratory analysis, those laboratory in your menu of services that are required for the sick population. When a hot zone is correlated to the decrease in the physician outpatient visits, routine inpatient and outpatient surgeries, as we mentioned, will be changed, and that will cause probably financial issues within your leadership structure of the hospital or health system. So we want you to know in the laboratory, because it is the definition of having COVID is getting a positive viral test. You're right at the point where the analyzer brings that result together, and we would be your partner to bring that in bulk, not just the test you're doing in your own laboratory, but the test across the region, across the county, across the state. And you need to know what's happening in your local area. Is the COVID pandemic accelerating or decelerating? When we're finished with this lecture, you'll be able to see that the HC1 CV19 Command Center, which is the central point of visualization of all the information services that we'll go over today, they all come together on one very dynamic screen, a dashboard, so that you can direct care within your care environment or to the population that you serve across. You can look at it across a micro community environment of an office building. If you're on a campus for a university, it could be to a dormitory or for a particular building that belongs to one of the colleges of a university, that you can monitor all the folks that are in that micro environment and monitoring them for their change in viral tests and what is the prevalence in the population that serves your university or serves your organization, but they're all breathing the same air that day. It's really what it comes down to, is being able to tell what is the risk, what is the prevalence of someone being positive in one of those microenvironments. Right now, before I hand it over to Josh to talk about how the whole technical software and the whole process is put together, I want to focus on this input, the HC1 Local Risk Index. This is unique to our program in terms of how we trace, how we trend, okay, and how we define the risk that could occur in one of those microenvironments or one of the counties that you serve. So why is this important? First of all, I don't have to tell this audience, but we have to go through in terms of the interpretation of the two key tests that are available. And there are different type of viral tests. To date, the PCR test has been the defining diagnostic test. Rapid tests are often used for rapid surveillance, that they have a high sensitivity so that you can pick up positives. But I don't know, physicians are not going to act in terms of making therapeutic decisions without confirming to a PCR test. The other is not what we call the antibody test, okay, as opposed to the virus test in our presentation. Okay, the antibody test obviously comes from the patient's blood, and IgM is one of the early immunoglobulins that develop, while IgG tends to trend later. So there's all this timing that happens in series to the patient. And that first column of the disease progression is before the patient's exposed. And what will happen, and it's picked up with about, I've seen 75% sensitivity in the days just before symptoms occur. The incubation period for this particular virus being fairly well defined now as between 4 and 11.5 days. So the viral PCR test will turn, that's those cotton swab tests, into the nasopharynx. Difficult to obtain, that's part of the issue of the sensitivity. Do you get a good sample? But then once on the analyzer, if a good sample is done, it will turn positive in the period as the symptoms would occur, or in pre-symptomatic or cases that are completely asymptomatic throughout the course of the illness for somebody. The viral test will generally appear positive coming into the 4th to the 7th day in a strong positive. The antibodies will initially be negative, but then you'll see that the IgM will turn positive with usually 7 to 10 days after the viral test is changed. And it will initially be higher in IgM than IgG, but then the IgM tends to go lower than the IgG. So the interpretation of this gets rather fuzzy, okay, unless you're using the viral PCR test for interpretation of whether the disease exists or not. You would not make a diagnosis of active COVID by using the antibody tests, because it's likely or not likely, possibly. But with all these right here, and this is a good chart to carry with you, is that do you quarantine, do you isolate the patient that has the positive viral test? And throughout this, you can see you would want to isolate them until the viral test goes negative and the antibody tests, okay, are positive. Now, we take all this data. Remember, there's 2,500 labs collecting this data. It's coming through, channeled to HC1, and we are able to then trend the positivity rates. What we have on the viral test is we have the name, which is later de-identified. We have the age, the date of birth. We have the location of the address for the individual, male or female, and gender. And we are able to trace all of this out. I'll show the whole database here in just a second, but this wraps it up in terms of when you're looking at an area, you can see the different public use micro data areas. These are sub-counties. Here in Tarrant County, in Dallas County, in Texas, where I live in a town called Southlake. Well, Southlake and the other suburb next to it called Colleyville, they are one micro data unit. And here you'll see that the LRI, which is defined as the percent positive of the tests done during the last week, the average daily positivity averaged over the last week for which there's complete data. And you can see the number of patients tested and the percent positivity. The percent positivity is divided by 1%. Okay, so the number stays the same, but the local risk index we issue is a single number because 1% is the level in a community where typical public health resources would be able to control with quarantine, isolation, quick identification of cases in the manner that we would do for measles, or we would do for rubella, or if there was meningitis on a campus. But this is a pandemic, and we have to go into, quite frankly, very significant mitigation type of maneuvers, the masks, the distancing, the no public gatherings of larger than 10 people. These are the strict mitigation, and all the way, if it's really taken off in an area, quite frankly, the complete stay at home, shelter in place order. Let me move to this example in Secaucus, New Jersey. It was one of the biggest hotspots at the beginning and one of our clients that we were working with. And you could see that the people, these were the areas of which they came to that office building, which is the blue dot. And so there was different risk factors for the residential exposure for the employees that came there. And therefore, you can trace these over time and see that different areas that are different colors. And in any one particular time, in the last 7 days, you can see that the local risk index, again, that number that reflects the number of positives divided by the number of tests done, okay, was much higher in certain areas. So when you bring the micro community together here at the Blue Dot in the office building, the folks here probably need a different level of intensity of, they may not have the virus, but they're coming from an area, and public health data out of in the past for these respiratory viruses have defined that people that get respiratory viruses of the coronavirus nature type that's COVID is, that 1/3 get them from their home residential area, 1/3 from the area of which they shop, go to church, and then 1/3 from where they go to school or they are in their office building. So 2/3 of the exposure comes from where the people come from. And if this is a university, then you have commuter students coming from at least these distances, if not, again, here in the New York area, crossing the bridge or the tunnel and coming over even from Manhattan Island. So let's take a look at this demo. What I'm going to show you is cv19dashboard.org. It is available now to anyone. There's a short, it takes 15 seconds to fill out the little request for your name and your email so that we pass a confirmatory email that gives you a key to get into the site. So anybody can sign up at this point. And I encourage you to do it because you can trace, your own community, or you can trace, and let me get to the right. Here we go. Another Windows on top. Josh, you wanted to make a comment while I'm pulling this up. Do you want to make some comment on terms of how you're taking the local risk index forward?
What I think what's very important to emphasize, Dr. P, you did a fantastic job reviewing it and overviewing it, but specifically for laboratory leaders, what's very important is that they have that data accessible to them to be able to manage their business, whether you're an inpatient laboratory, understanding what is happening locally to you, or whether you run an outreach business or you're an outpatient laboratory like the Big Four, where you are managing business on a sector by sector and geographic by geographic location. So using this tool to manage your volume based on what's happening geographically could be really important to either business retention or business expansion.
Let me show you again. And again, you can, I'm going to go share my screen so it doesn't do that flickering. Apologize if that was doing that earlier. So when you call up the website, here, let me pull this out of the way so you can see the web address is the one I gave you, cvdashboard.org. It will come up with this in terms of loading. It generally loads in about 10 seconds. And you'll see a relative rate of positivity, or LRI, the percent detected by state. Now, this is very interesting, but you can't manage patients. You can't manage a population of 350 people in an office building or an office, or 10,000 people on a campus based on a state map. But this does bring together and shows you how all the data comes in. And remember, it comes in one test at a time, and then it accumulates, okay, to these trends that we'll see. And we're also posting the antibody prevalence rates. Again, we will only post antibody tests that have the emergency use authorization from the FDA. There's hundreds of them now. But again, it has to have that EUA, or else we will not post the result. And again, you can see the viral testing on the left side with the orange-red colors and the blue tones on the right for the antibody. And here you see just in the last, this is actually from the current 30 days, okay? Just in the last 30 days, we've collected 3,262,000 plus tests. And of those, it's generally a 6% positivity rate across the country. I'd say this is a low titer. This is what I'm thinking is just basically our background percent positivity that's going to happen in this country, unlike others that drove it down to 0%. I don't think we're going to have a quieter period than this. And when fall comes, we would expect, and I hope not, but you tend to expect it's going to go way up as the flu season comes. We also define, for those that, this is interesting because there's repeat tests. And so we can identify that this actually means about 3 million individuals had the 3.25 million tests. So we're actually able to define that specifically. And then when we look at the percent positivity, we're looking at the number of people that are positive, not just the number of tests. So you actually have a population range, and the demographics come out by age in these bars of total tests done, or the percent positivity. Percent positivity is represented by these gold dots. And interesting, at the beginning of this epidemic, we were seeing it was the older ages of 80 and above, 70s and the 60s that had the highest positivity. And since Memorial Day, that has shifted completely so that the young people have the highest positivity rates now. And you've seen it on the news why. And we're seeing it now on college campuses with all the parties with no protection. More females get tested, but more males, when tested, are positive. Really confirms that women might take better care of themselves than the guys. And again, you can trace these over time. In fact, if I change this little variable up here, don't miss this, with this filter, you can actually change the range. So I could show you all the way back for 120 days. We'll go back, we'll just skip that for the moment because I want to focus for the time we have to look at what happens in the state here of Texas. You can use micro data units, which are defined by the federal government, that are generally parts of a county. And for this illustration, I'm going to do that. And it will list all the public use micro data areas of Texas. And if you've been watching the news, Texas has been one of the hot spots throughout the summer. On a statewide basis, it lists all of those micro data units, the LRI, in rank from highest to lowest. And you look at the relevance of that high one based on the number of tests that were done. And when you're local, you'll know what the population is there. We'll show you how we can see that on the map. And over time, whether you're in a small, just one unit, one micro data unit, or statewide, you'll see that we trend over time. And Texas has gotten milder. It was, one point, it was about averaging 25, 26% across the state. And the rolling number of 7 versus 7 is very important. That is, what was the average during the current 7 days versus the previous 7 days? You want this to be below 1. When it's 1, it means you have a steady rate. It could be a ranking of 10, but if it's at a ratio of 1, it means it was 10 last week and 10 this week. It's like a gyroscope on the front of a plane, and whether you're going down, decelerating, or accelerating. And for much of the summer, Texas was accelerating with rates above 1 up to 2. Let's take a look at a particular area here. This is along the Rio Grande border. It's the Rio Grande Middle Development Area. Defined here, it had a 33% positivity, okay? But the patients tested were 27 out of a population of 173,000. It's a very high percent, and this actually might have been a cluster of, one family had 27 tests, or a couple, one particular neighborhood had done that. But let's focus in and go a little bit to one of the more major areas. And I'm going to use Dallas because I know all the areas. And here, all these different colors are different neighborhoods within the 2-county area of Dallas County and around Fort Worth and Tarrant County. This is one area I've been watching very closely. It's the Irving, Texas area. It's been very high for over 3 months now. Again, in the population, almost all the Pumas have about 100, 120,000 people in them. That's why they're defined to have the same number of people in them, not just what the geographic size is. Again, we had 106 tested in that area and 21 counts in the current week being detected as positive viral tests. So you have the numerator, the denominator, it comes up to 19.8%. If we focus in on that particular area of Irving, this is the central part of a large north to south town that is just next to Dallas, and it's where the airport is on the western side of Irving. And you'll see this trend rate has been going up. And it came down as low as 8.75 in early August, but it's been drifting up despite the fact that everybody's paying so much attention, okay, to this. And this is what we're seeing. This is not a good situation when since the middle of August, we're seeing most of the time the ratio of the daily published 7 days versus the previous 7 days has been greater than 1. And up here, almost 2, 1.75, that it's doubling, it's nearly doubling every week. And that's what you would see. It would double from 10 up to 20. So you can do this on any neighborhood, anywhere across the United States, any county. There's 3,007 counties. And again, this is the basis of our data, okay, that we develop then into our product, which is HC1's workforce advisor product. Let me get back to here and hand it over to Josh.
Thanks, Dr. Pete. Really appreciate that. Great job reviewing the LRI and its importance. And again, to reiterate, its value to lab leaders, which is the audience watching this presentation, is really when you manage your current population, either in your inpatient facility or your outreach business, to know what's going on around you and to be able to manage to those clinical expectations. So if you're seeing a surge of cases based on local risk data that may correlate directly to increased inpatient volumes, which would be good for your anatomic pathologists and would likely change the direction that you staff your laboratory. Similarly, if you're in the outreach business and you see an increase in volume, that may directly correlate to an increase in either viral or antibody testing for your laboratory. And when you see a decrease in volume, that could directly relate to a decrease in your local area, resulting in your hospital possibly doing more elective procedures, also good for your anatomic pathologist and allow you to manage both your clinical and your histology labs accordingly. So the data is important from a public health perspective, but we as lab leaders can also use that data to manage our respective facilities and businesses. And I think that's important, being a lab leader myself. When HC1 looked at the COVID crisis, we said, being an informatics company, what tools can we offer the environment and the healthcare environment and also employers in a non-healthcare setting that would really benefit them getting employees, students, or anyone relevant back to work, back to a functioning position, whether it's in office or even at home or traveling. And we developed our workforce advisor, as Dr. Plantis referred to. We looked at really two key components or two distinct activities that were important for employers and including universities. And that was, do you qualify to come back to work? Are you able to safely come back to campus and stay safe and not infect others? And then how do you monitor your current health status on an ongoing basis? And so those were the two activities that we sort of based our product around. Next slide, please. So Workforce Advisor really contains 4 components to it. The first one is the command center. That brings everything together. So we take, as Dr. Pete showed you that slide earlier, that has all the various functions that flow into it. We can take Bluetooth technology. We take symptoms tracking. We take the local risk index data. We can take temperature data. We can take data from your human resources system. We take all those data feeds. We put them into one central location. So depending on the size and scale of the organization, it can be managed on a roles basis, roles access basis. So for example, in a hospital setting, it may be the employee health office. In a university setting, it may be the student health center. In a larger setting, where you may not have an employee health office, it may be at the supervisor level. You may have a chief medical officer for a large corporate organization. So it's roles based, but it allows you to pull all these different data feeds in and manage your populations appropriately. The second component is the symptoms tracking application. So having your employees or students go in on a daily basis, filling out a symptoms questionnaire. Are you feeling fever? You feeling loss of taste or smell? You feeling numbness in your legs? Whatever the current CDC recommended questions are, we incorporate those into our daily symptoms tracking application. That data also feeds into the command center. The third function was the local risk index, and Dr. Pete did a great job explaining that, so I don't need to go through the specificities. And the last component is integrated lab testing. And so we are, by our core values, a laboratory, precision laboratory company, precision testing, precision prescribing. And so we have interfaces to over 1,000 different laboratories around the country. And so we interface results into the command center. So it's testing, it's symptoms, it's location, and it's diagnostics. A bit more specificity into the various components. The command center integrates all the medical testing. It displays it by employee and work location. Dr. Pete mentioned that. It gives you local risk index, both at the employee or the student's home location and office location. So you can manage where your people are coming from and where they're going to and how safe is each of those locations. We can automate alerts via email, text message, really any way you want messages delivered, fax. And we can automate those on a pre-programmed protocols based on what your organization or subunit wants to deliver. Everything is roles-based, and we are a healthcare company, so we're all privacy-centric and HIPAA compliant. We've developed a phone tracking application, symptoms tracking phone application, so employees, students, even visitors can go in on a daily basis, plug in their symptoms to ensure that people entering your facility are not infected or feeling infected. It mitigates risk. We incorporate the local index. Dr. Pete did a great job. I don't need to go into that. And finally, integrating the lab testing, which is what it says it is. Next slide, please. The beauty of it is it's very flexible. It's flexible, it's agile. You can pick and choose. It's almost like a McDonald's menu. If some institutions only want the command center to manage data, we can do that. If some institutions only want the symptoms tracking, we can do that. Symptoms tracking comes with a daily badge. So when you enter in your symptoms, it says that on this day of September 1st, Josh Allen entered his symptoms. He displayed no symptoms that were of concern, and he's allowed to enter the campus or the facility. And so anyone who asks to see that badge on a daily basis, it'll be date and time stamped. So there's no chance of forgery. Next slide, please. This slide is a repeat, but it wants to show you the power of the system. It's configurable, it's flexible, it's extensible. We can take test tracking, symptoms tracking, lab testing, local risk index. All the data can be integrated directly from your ERP or your HRIS. We've interfaced with companies like PeopleSoft, Oracle, Workday. We have employee or portals. If you set up portals around your campus, digital ID, contact tracing when it becomes available. Now we have manual forms of contact tracing, Bluetooth temperature logs, and then any other systems we're able to interface into. Next slide, please. So this is a matrix of what a daily screening or testing and flow chart would look like. So if you start on the left and you move over to the right, employee starts the day off by taking a daily symptoms questionnaire. If they're asymptomatic, they're cleared to go on site and resume their activities. You restart the sample, the process the next day. if you're symptomatic, you follow the protocol internally to get a viral test ordered. You go to a laboratory. Those results, if negative, you would go home. You'd isolate at home till you had the results. Results are negative, you come back to work. If the results are positive, the purpose of showing you all these automated triggers are that we can really develop protocols around your needs. So for example, if you want to notify environmental services because you work on a major campus with 20,000 people coming in and out every day, we can notify environmental services to clean building Y. If you want email notification sent when employees test positive, assuming that they've consented to the system, we can email your CIO, your CMO, your employee health nurse. We can even email contact investigations to the Department of Health to say, hey, a patient or a student or an employee has tested positive and we wanted to report this to you. Finally, if you're an employer or a university or an employer where you have on-campus housing, we can notify your supervisor that you are reporting home for on-campus housing. In the case of the university, it would be a dormitory, and that you are to be isolated for a 14-day period. All this can be automated. It all flows back into the command center with the local risk index data. And as on the bottom right, you see the dashboards. All these become available in various level dashboards, which I'll go through in a second, so that management can manage the population and the risk to the population to continue your business continuity. Next slide, please.
Let me just make one comment here. It is not humanly possible to do all this with a clipboard and some graph paper or an Excel sheet. Again, you need the power of the platform to pull all this together. If you're going to get in a very timely action alert, get the positive person out of the population, whether that's a university or whether that's an office building.
Great point. Thank you very much. Okay, so I'm sorry I'm going through this so quickly, but I know we're running short on time. So I want to take you just through the dashboard so you can see what you're looking at. This is a high-level executive CEO dashboard. This tells the CEO every day, what do I need to know? How many people were tested, both for viral testing and antibody or antigen testing? How many of my employees are infected at any current point in time? How many are living in high-risk areas and coming to the office? How many of my offices, if I'm a multi-campus institution, how many of my offices are in high-risk areas? How many employees are in quarantine? How many employees have consented to allow to have their data? And so on and so on. Next slide, please. This breaks it down into a employee grouping level. So for example, if you run the IT department, this would give access to all the people in the IT division. It would show you what facility they work in. And it tells you that second column from the left tells you about the office LRI. So if your LRI is green, it means that your office is located in an area that has very low risk of COVID infection. If you go all the way to the right side of this graph or of this chart, it will tell you about the home LRI. So this tells you, where are my people coming from and where are they going and what is the risk that is presented to each of them. We also track vaccine status when it becomes available. In this slide, it's a no because there's no vaccine out. And we also track antibody and viral testing by last date of test. And then finally, as you scroll towards the right side of the graph, we talk about the symptoms tracker and who has reported symptoms. In this case, you can see that John Smith reported a questionable symptom in the past 7 days. So we'll drill down to that in a minute. And finally, we talk about consenting for both testing and monitoring. Next slide, please. We mentioned John Smith earlier. John Smith reported on his symptoms tracking that he had a questionable symptom, and so he probably would have been sent for testing, which I'll get to on the next slide. But in this case, we can see where John lives, where his office is, when his most recent viral and antibody testing were, and what his symptoms tracking history was, and then where is he coming from, where is he going. That's the local risk index. Next slide, please. Okay, so we talked about the symptoms history, and we can see that on May 28th, John reported a possible exposure. So he was near someone who was exposed and therefore was resulted in him possibly being exposed. And so if you move to the right side of the graph, you'll see the testing history. So on that day, John reported to the laboratory, he received a PCR test standard of care to detect active infection, and it was not detected. So John reported back to work. Next slide, please. Okay, that's the end of my presentation. Again, my apologies for going so fast. Dr. Plantis and I are available for questions after this presentation. Our contact information was as follows, and we recommend you reaching out to us and are happy to answer any additional questions that you may have on the local risk index, COVID-19 testing, HC1, workforce advisor, or bioinformatics in general.
And I would encourage you personally to trace where your grandmother is, or where your mother lives, or where your kids go to school, where your neighborhood. Sign up, get into cv19dashboard.org. I think you'll find it interesting. And if you just click through, you'll learn how to look at your own data. Thank you very much, and we appreciate the opportunity for the presentation today.
Take care. Thank you.